Hi everyone, welcome back to Next Level Ophthalmology. We're meeting after a long time. Sorry for the delay. I would like to start the new chapter on Uvea by paying respects to Dr. Nursing Era. Today's topics are relevant anatomy of the uvea and embryology and congenital anomalies. So the uvea is divided into the iris, ciliary body and the choroid. Even though the uvea is a continuum, we need to differentiate this because each disease like of the iris, of the ciliary body and the choroid have different presentations and have different therapeutic aspects. So let us start with iris, the gross anatomy. So the function of iris is to act as a diaphragm and to control the amount of light that enters the eye through the pupil. Okay, pupil is the central opening within the iris. It is a dynamic structure and we have gone through in detail about pupil. The iris has a central pupillary zone and a peripheral ciliary zone. Okay, and this division is marked by the zigzag line called the collarette. Okay, if you can see this collarette here, this zigzag line marks the pupillary zone from the ciliary zone. Okay, the central zone is relatively smooth, whereas the peripheral zone has a lot of crypts. So these are deficiencies within the stroma and these are termed crypts. Okay, these are the crypts that you see in the iris. And then there are furrows. Can you see these faint lines here? So these are like concentric lines which appear when the pupil is small. Okay, during dilatation, the iris folds on these lines. So coming to the microscopy, iris is probably the only tissue in the body in which the epithelium is behind. Okay, so the anterior most part is the anterior limiting membrane. Okay, and this layer decides the color of the iris. Right. Then next is the stroma. Okay, this part is the stroma. It contains the blood vessels and the muscles, that is the constrictor pupillary muscle, also known as the sphincter pupillae, and the dilator pupillae. Okay, so this is the stroma. After the dilator pupillae, there is the anterior epithelial layer, and then there is the posterior epithelial layer. Okay, let's take a question now. The layer of iris that decides the difference between these two eyes. Here you see two eyes. So here the main difference between the two eyes is the color of the iris. Okay, so the difference as we just learnt is anterior limiting layer. Alright. So there, if you closely observe, there is another subtle difference here. The pupil diameter is a little bigger in the first eye and the pupil diameter is smaller in the other eye. Okay. Why does this occur? Usually we see light iridis in people who are living in the west. The sunlight is not as strong as it is in the east or India. Indians have dark iris and small pupil. So people think that it might be an adaptation to bright sunlight that the pupil has become smaller in these areas. Okay. The next we'll start with ciliary body. The ciliary body is a ring-like structure, and when you take a cross section at this point, you will see it as a triangle. The apex of the triangle gives rise to zonules, and the base is in contact with the sclera. Okay. The anterior 2.5 mm is called the pars plicata because it has finger-like projections, and the posterior smooth part is known as the pars plana. So if you see the eye from a transverse section, here is the lens. The first 2.5 mm is the pars plicata, which has all the zonules, and then it continues as the pars plana. So this is the site for giving intravitreal injections. So what are ciliary processes? These are finger-like projections which are around 70 to 80 and are involved in the production of aqueous. Okay. Then if you take the microscopy, the outermost layer is called the supraciliary lamina, which is in close contact with the sclera. There is a potential space here, also known as the supraciliary space. Then next comes the stroma. Again, like iris, there is muscles in the stroma. So there are three type of muscles: longitudinal muscles, circular muscles, and oblique muscles. The function of oblique muscles have not yet been understood. The functions of longitudinal and circular muscles I will discuss in the next slide. The next layer is pigmented epithelium, and after that there is non-pigmented epithelium, and then the internal limiting membrane. So ciliary processes, these are the ciliary processes, okay, and from these arise the zonules that hold the lens. Okay, the ciliary processes are just a continuation of the epithelial layers with a central vascular core. So the outer layer is formed by the non-pigmented epithelium, the inner is formed by the pigmented epithelium, and then there is a vascular core. So these are actively involved in the formation of aqueous. So what are the functions of ciliary body? It's an important structure. The muscles, the circular muscles are involved in accommodation. That is, whenever these muscles contract, the zonules become lax. Okay. So remember, it's the opposite. When the muscles contract, the zonules become lax and the lens capsule also becomes lax. Okay. Next we have the, okay, when the lens capsule becomes lax, there is an increase in the bulge of the anterior lens surface, leading to a myopic shift in the refraction, leading to focusing of near objects. Okay, so this is the uh, mechanism of accommodation. Next, there are longitudinal muscles that attach to the scleral spur. So it's like a lid. So whenever these muscles contract, the lid opens and the trabecular meshwork which is attached to the scleral spur are stretched open. As a result, the aqueous has a chance to get drained through the trabecular meshwork. The next important function is production of aqueous, which I told you is from the ciliary processes. And then we have a blood aqueous barrier, which is a very important structure to maintain the integrity with respect to infections. Okay, so these are formed by zona occludens or the tight junctions that are present between the non-pigmented epithelium. Okay, let's take a question now. There is a patient with acute congestive glaucoma and he's been given intravenous mannitol. The major portion of water drawn from the eye is vitreous but not aqueous. What is the reason for this? Okay. There are tight junctions between the endothelium of retinal capillaries, the tight junctions between the cells of retinal pigment epithelium. There are tight junctions between the cells of non-pigmented epithelium of the ciliary body, all of the above. So this case typically illustrates the function of a blood aqueous barrier that is formed by the tight junctions between the cells of the non-pigmented epithelium of the ciliary body. As a result, whatever drug is injected intravenously does not gain access into the aqueous that easily. So as a result, the fluid that is drawn is from mainly from the vitreous but not from aqueous when you give intravenous mannitol. Okay, so this is how the epithelium. This is the pigmented epithelium. This is the stroma, and this layer is the non-pigmented epithelium of the ciliary body. So here, can you see these are the zona occludens which form the blood ocular barrier. Okay, choroid. It is the posterior most part of the uvea and extends from the pars plana till the optic disc. The color is brown because of pigments, and this is the reason for the brown appearance of fovea. In the fovea, the retinal layers are thin, and that's why the fovea looks a little more brown than the rest of the retina. The space between the choroid and the sclera is a potential one and is maintained by negative pressure. So this is known as the suprachoroidal space, and it gives space for the long posterior ciliary arteries and the short posterior ciliary arteries. Coming to the microscopy, there is sclera, and then we have the lamina fusca, after which we have the layer of large choroidal vessels also known as the Haller's plexus, and then we have the Sattler's plexus that are smaller than Haller's plexus, and then the innermost is called the choriocapillaris. Okay, there is no E in this, there is a choriocapillaris. So these form the capillaries of the choroid. And next to that we have the Bruch's membrane and the retinal pigment epithelium, after which the retina starts. So what is subretinal space? What is sub-RPE space? So embryologically speaking, retina contains only the neurosensory retina because the RP is developing from some aspects of the choroid. Alright. So whenever someone says retinal detachment, there is a separation between the neurosensory retina and the retinal pigment epithelium. So subretinal space means space between the neurosensory retina and the retinal pigment epithelium. When we see sub-RPE space, that is the space between the retinal pigment epithelium and then the Bruch's membrane, which is nothing but the basement membrane of the choriocapillaris. Okay. So what are the characteristics? All are the characteristics of choroidal vessels on fluorescein angiography. So fluorescein angiography is an invasive test in which a dye called fluorescein, sodium fluorescein, is given intravenously, and the pictures of the retina are captured through a blue filter. Okay, so this property of the dye to absorb one wavelength and to emit the other is known as fluorescein. Okay, so it absorbs blue light and emits green light. So whenever the dye enters the choroidal vasculature before the retinal vessels, this is true because the choroidal vessels appear before the central retinal artery. Therefore, the dye appears in the choroidal vasculature before appearing in the retinal vessels. So, the choroidal vasculature appears like branches of tree. No, this is false because retinal vessels are the ones which appear like branches of tree. Choroidal vessels appear like lobules. Okay, the blood supply is in the form of segmental blood supply, and thus they appear like lobules on angiography. Occlusive diseases of the choroidal vasculature appear as wedge-shaped defects. This is true. The cilioretinal artery fills up with dye before the central retinal artery. This is also true because the cilioretinal artery is a branch from the ciliary circulation, which appears before the central retinal artery. Thus, the cilioretinal artery always fills up before the central retinal artery. So the right answer here is B. Let's understand the blood supply of uvea. All the blood is derived mainly from the ophthalmic artery, which is a direct branch of the internal carotid artery. Okay, so from the ophthalmic artery, we have the short posterior ciliary arteries that pierce the globe from posteriorly around the optic nerve and then supply the choroid. There are two long posterior ciliary arteries that pierce the globe from posteriorly, and then they run along the suprachoroidal space and to reach the ciliary muscles. The ciliary muscle is supplied by the long posterior ciliary arteries, and then they continue ahead to form the major arterial arcade here at the base of the iris. The anterior ciliary arteries are derived from muscular branches of the ophthalmic artery. They are 7 in number, 2 for each recti, that is superior rectus, medial rectus and the inferior rectus, and there is one artery for the lateral rectus. And they pierce the sclera near the limbus and they form the anastomosis with the long posterior ciliary artery. So the iris derives its blood supply from the radial vessels. So from this major arterial circle, which forms a circular network of vessels around the iris, radial vessels enter the iris, and again at the pupillary margin they form the minor arterial circle or circulus arteriosus minor. So this is how the blood supply of uvea happens. So there's a clinical implication of this blood supply. So whenever there is trauma to the iris, there is no bleed, okay, because these vessels get occluded by the contraction of muscles, something similar to the uterus, okay. But when there is an avulsion of the iris root, the bleeding can be profuse because you have the major arterial arcade there. So these patients may present with a hypema. Let's take a question at this point. False about metastasis to choroid are all except it is the most common site of metastasis in the eye. This is true because choroid is a very vascular structure. In women, the most common site of primary leading to choroidal metastasis is breast carcinoma. This is also true. We are looking for a false statement here. In men, the most common cause of choroidal metastasis is prostate cancer. This is false. We have found that it is lung cancer according to the literature. So it's not prostate cancer. Choroidal metastasis is usually post-equatorial. This is also true. So equator is the imaginary line that dissects the eyeball into an anterior and a posterior half. So it is around 15 mm from the limbus. Okay. If the total distance from the limbus to the posterior pole is around 30 mm, equator is halfway. So it's around 15 mm from the limbus. So this is where the equator is. So most of the choroidal metastasis happen in this part of the choroid. The right answer here is C. Okay, let's learn about the venous drainage. In the iris and the ciliary body, the veins of the iris run towards the ciliary body and join the veins of the ciliary body. From here, they form the anterior ciliary veins and pierce the sclera and enter the orbit. Okay. Whereas the choroidal blood is drained through the vortex veins. Vortex means whirlpool. So these uh, veins on fundoscopy appear like a whirlpool or a spider. So these are known as venae vorticose. They are four in number and located on either side of the superior and the inferior rectus. So suppose this is superior and the inferior rectus. There is one superotemporal vortex, supranasal, infranasal and inferotemporal. So this is the order in which they are present from posterior to anterior. So superior temporal being the most posterior and inferotemporal being the most anterior. So from here the superior vortex veins drain into the superior ophthalmic vein and the inferior vortex vein drain into the inferior ophthalmic vein. So these are present 6 mm posterior to the equator. We just now discussed where the equator is. So from the equator 6 mm behind is the position of these vortex veins. So this is a picture showing you the vortex veins which are situated in the 6 mm behind the equator. So there are four major vortex veins that you see here. Okay, so like we discussed, supratemporal, infratemporal, infranasal and supranasal. Okay. Pick the wrong statement concerning choroidal vessels. Choroidal vessels do not have autoregulation. This is true. So autoregulation is seen in few organs in the body, namely the brain and the kidney. The next is retina. So autoregulation is a phenomenon by which a tissue or an organ controls the amount of blood that leaches itself. So this depends on the tissue PCO2. If the PCO2 is more, there is vascular dilatation. If the PCO2 is less, there is vasoconstriction. Okay. So this is how there is autoregulation, which is completely lacking in choroidal vessels. In choroidal vessels, the caliber of the vessels is directed by the systemic blood pressure as well as the hormones like epinephrine. Whereas vortex veins have a smaller caliber compared to retinal vessels, this is false because we have seen that the vortex veins are much bigger than the retinal veins. The inferotemporal vortex vein is the most anterior. This is true. We just discussed this. The superior vortex vein drains into the superior ophthalmic vein. This is also true. So the right answer here would be B. Vortex veins have a caliber bigger than the retinal vessels. So let's come to congenital anomalies of uvea. Let's deal a little bit about embryology. The uvea is mainly derived from the vascular mesenchyme that surrounds the optic cup. Okay, so the epithelium of the iris and the sphincter muscles are derived from the neuroectoderm, whereas the stroma and the blood vessels are derived from the vascular mesenchyme. Similarly, in the ciliary body, epithelium is derived from the neuroectoderm, whereas the stroma is derived from the vascular mesenchyme that surrounds the optic cup. Again, the choroid is derived from the vascular mesenchyme, and the melanocytes that are present in the choroid originate from the neural crest. So let us begin with uveal coloboma. The relevant embryology here is when the development of the lens commences in the early gestation, there is an optic vesicle that starts to develop from the superior and the lateral aspect. This optic vesicle starts closing on itself, and it usually starts by 5th week of gestation. By 6th week, this fetal fissure closes. Through the fetal fissure, there is an entry of hyaloid artery which supplies the lens. So, failure of this fetal fissure to close even by the end of 7th week leads to the formation of coloboma. So, if you can see this diagram here, this is the anterior portion of the fissure and this is the posterior portion of the fissure. So, whenever there is a delay in closure of this portion of the fissure, you can get iris colobomas. Whenever you see choroidal colobomas, you know that the problem was somewhere at the posterior aspect. So when the whole fissure does not close, you get a continuous coloboma right from the iris till the choroid, and this is known as a complete coloboma. So coloboma in Greek means mutilation and it is the congenital absence of a tissue. So the normal position of a coloboma or a typical coloboma is seen usually in the inferonasal quadrant. So colobomas can be there in the lids, iris, lens and the choroid. So typical iris coloboma is shown here and is seen inferonasally. It may involve the ciliary body, the zonules, the lens, the choroid and sometimes the optic nerve also. Such cases the pupils do not dilate very well. The choroidal coloboma is shown in the second picture here and is seen as a white area due to exposure of the underlying sclera. Okay, so it's also known as a retinochoroidal or an RC coloboma. The visual acuity is highly variable in these cases and depends on where the coloboma is. So if the coloboma involves the macula, then the visual is decreased. If the coloboma involves the disc, then also the vision is less. So there is a classification for coloboma by Idaman and this is shown here. So as you see from types 3 onwards, the visual prognosis is much better because they do not involve the macula or the disc. Okay, so some people advocate the use of laser at the margins of the coloboma to prevent retinal detachment. Let's take a question at this point. True about coloboma of the uvea is corneal notching does not have any correlation with uveal coloboma. Corneal notching is whenever there is a coloboma in the inferior nasal aspect of the iris, there is a little peaking of the cornea in that quadrant. Okay, so this is true. So corneal notching may be present, so this statement will be false. Usually they have congenital cataract. Again, this is false because these patients usually tend to have zonular coloboma, loss of zonules in that area. They do not have a congenital cataract. They are predisposed to developing retraction and retinal detachment. This is false. They do develop retinal detachment, but it is due to rhegmatogenesis because there might be holes in the end of the on the margins of the coloboma. So may be associated with lens coloboma. This is true. So the last option is correct. The next congenital anomaly is persistent pupillary membrane. So the lens is supplied by a fine network of capillaries known as the tunica vasculosa lentis, which gets absorbed by the time the child is born. A failure of this tunica vasculosa lentis leads to a formation of this spider web-like appearance on the pupil. So you see fine shreds of tissue that bridge the pupil, and the edges, if you can trace them, is attached to the collarette, okay, which is the embryologic origin of this tunica vasculosa lentis. So these never interfere with vision. And how do we differentiate this from an inflammatory membrane? The inflammatory membrane begins from the pupillary margin as against persistent pupillary membrane which begins from the collarette. A 20-year-old man was found to have a persistent pupillary membrane on routine examination. What points in slit lamp examination confirm that it is congenital and not post-uveitis? Okay, there are subtle points that you see on slit lamp that will guide you and say that this is probably a congenital condition. Pigments on the endothelium. This is very characteristic of uveitis and you do not get this in congenital cases. So pigments on the endothelium do not support congenital. Find numerous regularly arranged pigments on the lens capsule. This can be seen in both congenital and post-uveitic conditions. Okay, sometimes these pigments arising from the collarette can get deposited on the lens capsule. Pigments on the trabecular meshwork and the posterior synechiae are very typical for uveitis and not seen on congenital persistent pupillary membrane. So the right answer here is B. The next anomaly is albinism. So there are mainly two types, oculocutaneous albinism and ocular albinism. Oculocutaneous albinism is an autosomal recessive condition and ocular albinism is an X-linked condition which can be partial or complete. So depending whether the melanin is produced or not, it is differentiated as partial and complete. So melanin is completely absent from skin, hair and uvea, giving the typical look of albinism. So there are a few syndromes associated with albinism. They are Chediak-Higashi and Hermansky-Pudlak syndrome. So what are the clinical features? In the eye, you have the pink appearing iris because of extreme thinning of stroma and absence of pigments. So when you shine light, this is through a undilated pupil. If you see, this is the pupillary margin here, and through retroillumination, you can see the whole lens here. Okay, the iris is so thin that you can see the lens, and these are the zonules of the lens. So this is how a typical albinotic iris looks. So as a result, they have a lot of photophobia and they cannot move as freely as in daylight. In the choroid, the pigment is absent and this is also known as a tigroid fundus. It appears like tiger stripes. The choroidal vessels are very prominent because the pigments are missing from the choroid as well as the retinal pigment epithelium. Okay. Then there is an association. Here we get a foveal hypoplasia. The fovea does not develop well in these patients. As a result, they have a very poor central vision. Their vision might be somewhere around 660 to 3 by 60, and as a result, they have pendular nystagmus. So these are the ocular features of albinism. A 10-year-old fair-skinned boy with light hair presented with difficulty in reading small print even with glasses. Okay, there are a few clues in here. So we are saying a fair skin boy, light hair. So there is pigment absent from the skin as well as the hair. So he has problem with near vision also. On examination, he has pendular nystagmus and transillumination defects in a hypopigmented iris. So this line is a giveaway and it tells you that we are dealing with oculocutaneous albinism. So what is the fundus finding expected in this child? Optic disc pallor, pale retina, foveal hypoplasia, and retinal arterial attenuation. So the right answer here is foveal hypoplasia. The fovea fails to develop. As a result, the central vision will be very low. So Chediak-Higashi syndrome is presence of albinism along with recurrent pyogenic infection and lymphoproliferative disorders, whereas Hermansky-Pudlak syndrome is characterized by platelet abnormalities, pulmonary fibrosis, and granulomatous colitis. Coming to heterochromia, this is A common occurrence that you see, variation in iris color between the two iris is termed as heterochromia iridum, and variation of iris colors in the same eye is termed as iridis. So you can remember iridis has an S, so it is the same eye. So the first picture is that of a iridum, and the second picture is of a heterochromia iridis. So there are some congenital disorders that are associated with heterochromia like Waardenburg syndrome, which has sensory neural hearing loss in white forelock, congenital Horner syndrome, in which there is meiosis, ptosis, along with heterochromia. Okay, so presence of heterochromia differentiates congenital from acquired Horner syndrome. Other acquired causes are following intraocular surgery, post-uveitis, Fuchs heterochromic cyclitis, and pigment dispersion syndrome, which cause loss of pigments from the iris, giving it a heterochromic appearance. Aniridia means absence of iris. When it is associated with trauma, complete avulsion of iris, it is known as iridremia. Okay. So aniridia is a congenital absence of iris. Many a time you can see a thin stump of iris, like in this picture. You can see this clearly. They have angle abnormalities, and they are predisposed to develop congenital glaucoma, and also they might have foveal hypoplasia. The WAGR syndrome is a common systemic association in which you'll have to rule out Wilms tumor, genital abnormalities, and mental retardation. So another syndrome that can be associated with congenital anomalies of uvea is charge syndrome, which is usually seen in colobomas. You have to suspect this, especially when there is a RC coloboma that is bilateral. So C stands for coloboma, H stands for heart defects, which include tetralogy of Fallot and other things. A is choanal R is renal anomalies, genital anomalies, and E is ear anomalies. So what is reverse heterochromia? So heterochromia is loss in pigment. Reverse heterochromia is increased pigmentation, and it is seen in siderosis bulbi. So this is about congenital anomalies and embryology of uvea. We'll meet next week with uveitis. Thank you.